So we've looked at non-pharmacological pain relief, so not using any drugs, just using natural methods. We're now going to look at the drugs that you can use, or the pharmacology that you can use for pain relief. And there's 5 main: paracetamol, codeine, gas and air or Entonox, injectables such as dimorphine and pethidine, and then finally epidural. So Karen, from your point of view, because obviously being a home birth midwife, you saw women using paracetamol and codeine probably more frequently, and gas and air as well.
Yes, and I think for women in early labour, it can be quite effective and something that should be in your toolbox really. So paracetamol, I think the important thing is when you're having a long latent phase, is that you don't actually overdose on paracetamol. So make sure that you check the packet and that you just have the 8 tablets within 24 hours and that you space them evenly throughout. Now codeine is great as well. It can have a more relaxing effect than paracetamol can. It can just help you get that little bit of rest that you might have needed when your contractions are a little bit on and off at the beginning of labour, the latent phase that we talked about earlier.
If we're going to talk about gas and air, again, this is known as Entonox, and this can still be used at a home birth. Your midwife would just take it out with them, and it's also available in hospital. And you inhale it. So it usually comes with a big tube and a mouthpiece. And when you're starting to feel that sort of butterfly feeling that your contraction's just about to start, you just breathe slowly in, slowly out through the contraction. It takes a good 5 minutes for it to build up enough so that you actually feel the effect. It makes you feel like you're on the back end of 4 double G&Ts, doesn't it? Mm. So it really is effective, but it takes that 5 minutes. So a lot of times, you know, women will try it and take 2 puffs and say it's not working. And you've almost just got to persevere a little bit with it. Because again, like paracetamol, like Entonox, and codeine, it just takes the edge off. And for a lot of women, that's all they need, is just to take the edge off just at that peak of a contraction.
I think it's also important to know that if you do take the gas and you absolutely don't get on with it at all, then what you can do is you can just stop taking it and it's out of your system within a couple of minutes, totally gone, and you feel normal again.
So if we talk about dimorphine now, so dimorphine is, well, I mean, it's heroin. You know, obviously it's pure, but it's pharmaceutical grade heroin. And it's a phenomenally strong pain relief, but it can be used in the early stages of labour. So if you have had a really, really long latent phase and you just feel absolutely exhausted, for some women, this might be the option that works best for them. They might have found that paracetamol and codeine, they've maybe used the maximum amount there. It's maybe too early in labour for Entonox to really be a useful tool. And they may want to avoid an epidural. So dimorphine may be of their, you know, the drug of their choice at that time. So it's given as an injection, full dose, half dose, you know, talk to your midwife about that. Very much depends on where you are in labour. So if you're close to giving birth, it may be that your midwife maybe counsels you against taking it because it can have a really quite sleepy effect on your baby. It will make you very, very sleepy too. Some women report that they can't remember much about their birth, especially if they've had the dimorphine late on in labour or they've had a number of injections. So it is something to think about, especially the fact that your baby's sleepy.
Pethidine, that's another form of the opiate. That is more likely for you to have the memory loss and feel a little bit dizzy and not with it. And the dimorphine seems to work a little bit better. So if you can choose between the two of them, then it might be worth bearing in mind that dimorphine works a little bit better.
If you're breastfeeding, just keep that in mind as well, that if you've got a sleepy baby, sometimes they'll be sleepy for 24 hours until the dimorphine's out of their system. So it can make breastfeeding a little bit tricky. So you may need to hand express your breast milk or your colostrum and then give your baby that as well if they're really reluctant to feed. Finally, we've got epidural. So the epidural it's an anaesthetic. So it's actually given by an anaesthetist who is a doctor. They've gone through medical school and they've trained as an anaesthetist. It's a very sterile procedure. So You'll have green drapes on your back. The anaesthetist will be scrubbed up. They'll have a mask on, sterile gloves. Now, the procedure itself takes about 20 minutes, and the actual medication to start working and giving you an effect of pain relief takes about another 20 minutes. So all in all, start to finish, it's about 40 minutes before you can get some relief from it. Now, an epidural, it's the only form of pain relief really that's available to labouring women that will offer the obliteration of pain. So for about 9 out of 10 women, they will have no sensation of pain, and they should still be able to move their legs. If you need to have quite a few more additional doses of epidural, so say you're maybe that 1 in 10 that it's not quite working well enough, what you may find is that you start to lose that movement in your legs, that your legs feel really, really heavy. So that's another thing to just bear in mind, that you won't be mobile. So if you do decide that you want to have an epidural, you won't actually be able to walk about. Because you can't walk about, you'll often be advised or offered to have a catheter placed into your bladder just to help you empty your bladder and just keep it empty. I think the most important thing about an epidural is, though, as much as there are risks with it, I think they're quite overstated a lot of the times. And one of the biggest risks is that you can get something called a posterior tap headache. And that's about 1 in 50 women will have that. And there's a procedure that can be done afterwards just to help clot over that little hole. Now, because the anaesthetist is doing this, they have to be free. Now, anaesthetists will be doing the spinals and epidurals for operations, for emergencies, for that sort of thing. So as much as you may want an epidural at that time, it was very much dependent on when that anaesthetist will become available.
You need a cannula in your hand. That's just in case your blood pressure drops, and we need to give you fluids through that in order to counteract that. I also think that having an epidural can be sort of something that women think, oh my God, I can't have an epidural because that is, really frightening to me. But when you look at this, which is, that obviously you need a needle to insert the epidural, but this is really all that is left taped to your back. So this tiny weeny little line here, it's called an epidural catheter, and this bit goes into your back to feed the drug in, and then this will just be taped onto you there.
I mean, we'll not show you the epidural needle because you don't actually feel it at all. The epidural, before it's even put in, you get some local anaesthetic in your back, and it's just the tip of this tiny thin needle that actually injects the anaesthetic.
And it's totally numb then, isn't it? It's just pressing that you feel
that's
onto your
just
back.
Pressure. And because you're feeling pressure, you can't discern what is pressure from the anaesthetist finding the space and actually placing the needle. So if you just remember, it's this tiny, tiny needle and then this little thin tube. And if it's not working, so for some women, it doesn't work. But there's lots of things that can be done. They can just pull the tube back a little bit. In some cases, they can reinsert it as well. It used to be that some hospitals wanted babies to be monitored because of an epidural, but we've moved away from that a lot now. So if everything was fine with your pregnancy and there was no reason beforehand, just having an epidural doesn't really necessitate.
You need to be monitored beforehand, but then they can take the monitoring off.
Yeah.
And then pop it back on if needs be.